So we'll be starting with Cushing's syndrome. So what is Cushing's syndrome? It is basically the tissue response to hypercortisolism of any cause. While Cushing's disease is increased glucocorticoid levels because of ACTH secreting pituitary adenoma. So Cushing's can be of genetic or acquired nature. So the acquired deficiency of 11 beta HSD type 2 enzyme, which converts cortisol to cortisone. So there will be excess of cortisol, which has both mineralocorticoid plus glucocorticoid action, while cortisone only has glucocorticoid actions, and this is responsible for the various effects and clinical features of the disease. While the genetic component of the Cushing's disease is basically the most common gene affected in Cushing's disease is USP8. Most common gene affected, USP8. Okay, it accounts for 40% of the cases, and what it does is it increases the epidermal growth factor, which in turn increases the POMC, mineralocorticone, and this causes corticotropin, and it causes increase in ACTH levels, which in turn causes cortisol increase. So this is the most common genetic cause. Now this is the most common genetic cause in case of Cushing's disease. So Cushing's disease, most common genetic cause is USP8, while Cushing's syndrome, because of adrenal adenoma, the most common gene affected is PRKACA, while we'll come to a disease AIMAH. Here it is a ACTH independent cause of Cushing's, causing increase in inter/intra adrenal cortisol. So here the mutation is going to be in ARMC5. While in McCune-Albright, the most common somatic mutation most common mutation, which is actually a somatic mutation, is going to be a GNAS mutation of the G alpha domain, which is the activating domain. While in Carney's complex, the most common gene mutation is going to be PPNAD, causing PRKAR1A. PPNAD is primary progressive micronodular adrenal disease. Primary progressive micronodular adrenal disease. Again, a ACTH independent cause. Okay. So now we come to the causes of etiology. Most common cause of Cushing's syndrome is exogenous administration or drug intake, whether oral or otherwise. Now, the most common cause of endogenous Cushing's syndrome is ACTH secreting pituitary adenoma or Cushing's disease. And most common cause of Cushing's in an infant is going to be McCune-Albright syndrome, which basically presents with multiple fibrous polyostotic dysplasias. Along with that, it has Cushing's syndrome. Along with that, it has precocious puberty. And lastly, the most common cause of Cushing's in a toddler, that is 2 to 5 or 1 to 5 years of age, is going to be adrenocortical carcinoma or ACC. Now we come to the classification. So the classification is going to be based on whether it is going to be ACTH dependent or ACTH independent. So the ACTH dependent comprises of around 90%, while this is 10%. Now among the 90%, 75% is Cushing's disease. It is pituitary adenoma. Okay. while 15% is going to be ectopic ACTH secretion. Now that is going to happen most commonly with bronchial carcinoid. Bronchial carcinoid followed by small cell lung carcinoma followed by medullary thyroid carcinoma. All right. So this accounts for 90% of the Cushing syndrome, which is ACTH dependent, among which 75 is pituitary adenoma, 15% is ectopic ACTH secretion. All right. So after this we come to ACTH independent. So here the main things are going to be adrenal adenomas, adrenal carcinomas, primary progressive micronodular adrenal disease, macronodular adrenal hyperplasia, then it is going to be McCune Albright syndrome, then it is going to be AIMAH, ACTH independent macronodular adrenal hyperplasia, or also known as bilateral adrenal hyperplasia. So the interesting part about this disease is actually it is a food dependent Cushing's. So what happens? The receptor changes. Like when we take food and there is increase of GIP-1, glucagon inducing peptide. I am forgetting the, it is glucagon inducing peptide 1, which is an incretin, and this will cause increase in cortisol levels. So this is called as AIMAH. This will cause adrenal activation causing cortisol increase. So this is the classification of ACTH dependent and ACTH independent type of Cushing's syndrome. So now how will we differentiate between ACTH dependent, in which there were two types? One was the pituitary adenoma, while other was ectopic ACTH. So in pituitary adenoma, it is basically a female preponderance disease. Causes weight gain, causes protein catabolism, quite often. While here, weight gain may or may not occur. and protein catabolism occurs, but to a lesser extent. Hypertension is seen in around 50% of the cases, while hypertension in ectopic ACTH is seen in around 75 to 100% of the cases. This is a very, very important point. And hypokalemia is going to be seen here only in ectopic ACTH, because mineralocorticoid activity is going to get increased. So aldo is going to get increased and potassium is going to get reduced. Along with that, hydrogen excretion is going to go up. So it is going to cause metabolic alkalosis and hypokalemic hypertension. So this is a cause of hypokalemic hypertension, ectopic ACTH. Okay. Now, in case of pituitary adenoma, the risk of, this is a cramming point, risk of osteoporosis and vertebral fracture is going to be more, which is not going to be here in ectopic ACTH. Now ACTH is going to be around more than 20 picograms, while in ectopic ACTH it is going to be much more, 90 picograms. Now we'll come to this test, HDDST, high dose DEXA suppression test. In pituitary adenoma, it is classically suppressed. This is a very, very key point and one needs to remember this. So in HDDST, the pituitary adenoma, here it is going to get suppressed, while ectopic ACTH is never going to get suppressed. Not suppressed. And CRH response is going to be positive here. Why? Because the hormone is flowing in the same rhythm, so CRH can act. While in ACTH, ectopic ACTH, the ACTH is already very high. There is loss of pulsatile nature, so no effect of CRH. So this is the difference between pituitary adenoma and ectopic ACTH. And now we come to endogenous Cushing's and exogenous Cushing's. So in case of exogenous, and here it is endogenous. So exogenous is because of drug intake. So what is going to happen is the features that are going to get increased are going to be pancreatitis, glaucoma, posterior subcapsular cataract, osteoporosis, and avian of hip. While the ones that are going to get reduced are going to be hypertension, and there is going to be no pigmentation and no hirsutism. Okay, while in endogenous, because ACTH is going to get increased, so what is going to happen, there is going to be more cortisol levels, and 11 beta HSD2 is going to get saturated. So because of more ACTH, there is going to be more hypertension, more hirsutism, and more pigmentation. So these are the differentiating points. One, hypertension is going to get reduced in exogenous while increased here. There is going to be no pigmentation, no hirsutism in exogenous, while hirsutism as well as pigmentation are going to be feature of endogenous Cushing's. Okay, and so we come to the clinical features now. Clinical features. So clinical features of Cushing's are going to be because of A, increased carbohydrate metabolism, that is increased gluconeogenesis causing adrenal diabetes. Then there is going to be fat metabolism. Here the patient is going to have fat redistribution. So the fat redistribution is going to take place in this manner. There is going to be centripetal obesity. There is going to be very thin limbs known as lemons on stick appearance. Then there is going to be fat deposition in supraclavicular fossa known as collar sign. Okay. Then there is going to be deposition in the dorso-cervical area known as buffalo hump. Okay. And also in the spinal epidural area causing spinal epidural lipomatosis. Okay. This occurs in only 2% of the cases. Now there is going to be protein metabolism. So there is going to be protein metabolism, mainly catabolism, causing muscles to break down, proximal myopathy. Okay. Then there is going to be osteopenia, osteoporosis, short stature, that is low linear growth velocity. Then there is going to be breakdown of collagenous proteins causing purplish stria. Then the skin is going to get parchment paper skin or cigarette paper skin, causing tenting over skin known as Liddell's sign. Okay. Then defective platelet adhesion is going to cause easy bruisability, delayed wound healing. There is also going to be facial plethora. Then because of some sex steroid action, it is going to have hirsutism, acne, and amenorrhea. Okay. After that, because of mineralocorticoid action, there is going to be hypertension, metabolic alkalosis, and hypokalemia. It can cross, cortisol can cross the blood-brain barrier, causing psychosis as well as depression. Now the cardiac manifestations. They are going to have hypertension, atherosclerosis, plus dyslipidemia. Then most common menstrual abnormality is amenorrhea because of androgen axis. In blood, steroids always cause demargination. That is, if this is the blood vessel and here are the WBCs. So when the steroid comes, they will demarginate towards the center and this will cause a feeling of apparent leukocytosis. Plus eosinopenia. So another condition that causes eosinopenia other than Cushing's, one is Cushing's, another is enteric fever. It is a hypercoagulable state. Skin over the legs can get depigmented and pigmented in certain areas, causing a feature of tiger skin. Okay. So these are the things that we need to take care of. Now we come to ACTH independent causes. So the most common among them are going to be adrenal adenomas, adrenal carcinomas. So in case of adrenal adenomas or adrenal carcinomas, what we need to know is that these are known as incidentalomas, incidentally detected on CT adrenals or CT abdomen, and 90% of them are benign. Among those 90%, 65 to 70% are going to be inactive endocrinally, while 15 to 20% are going to be 15 to 20% are going to be active among which the most common is going to be is a Cushing's syndrome, and the second is going to be pheochromocytoma. Another question they ask is, what are the features of malignant incidentalomas? One is the size, more than 4 centimeter. One is the CT attenuation of more than 10 Hounsfield units, and one is less than 40% of contrast washout. All right. So these are the areas in which we need to understand where the incidentalomas can be malignant. Now, if this happens, malignant incidentalomas happen, then the treatment of choice is going to be unilateral adrenalectomy. Okay. All right.